The following podcast is part of a certified educational activity titled Expanding Frontline Frontiers in Multiple Myeloma, Insights on Delivering Modern Care with Innovative CD38 Quadruplet Platforms. Access the entire activity and complete the post-test at peerview.com/QTT860. Downloadable slides and practice aids are also available.
Okay, ladies and gentlemen, dear colleagues, dear friends, and we have a wonderful session. I can guarantee you will like this one. And this is about expanding frontline frontiers in multiple myeloma, specifically insight on delivering modern care with innovative CD38 quadruplet platforms. How CD38 antibodies work, don't worry guys, I won't spend 1 hour to explain this to you. We know we have 2 approved anti-CD38 monoclonal antibodies, namely daratumumab and cetuximab. And these are not like, the same, it's like the story of, I say always, antibiotics. It's a family, the target is the same, but the mechanism of action can be different, and there are some clear different features in terms in terms of activity on the tumor itself, but also on the microenvironment, where we do have actually, for instance, immune modulation and inhibition of the ectoenzyme activity in the case of cetuximab, whereas there are some data about depletion of immunosuppressive or regulatory cells in the case of daratumumab. And of course, you are well aware, and we heard a lot about this during this meeting, including this morning, about the current approvals of cetuximab and daratumumab. Cetuximab has been approved thanks to the ICARIA and IKEMA trial. Daratumumab has been approved thanks to MAIA, to Alcyon, and to Cassiopeia, and many other trials, of course, Pollux. Okay, so the other problem before leaving the microphone to my colleagues is that despite progress, I believe more work is needed to integrate CD38 platforms into first-line therapy. And here we have some real-world data from more than 2,000 patients treating in the 2021. So that wasn't, usually sometimes you have real-world data from 20 years ago or 10 years ago. This is quite recent. And you can see really a huge variety of approaches, and actually only 25% of 401 patients with newly diagnosed multiple myeloma received first-line a CD38-based treatment, and only 14% quadruplet. So our goals for today is to improve your knowledge of the latest safety and efficacy evidence supporting the use of CD38-based quads in newly diagnosed multiple myeloma. Hopefully will help to improve your skills and what you need to integrate CD38-based quadruplets into personalized upfront treatment plans. Last but not least, to enhance your ability to address care delivery considerations when using these quad anti-CD38-based regimen, including dosing and safety consideration. So without any further ado, I'd like to invite Dr. Josh Richter from New York, who will explain how to deploy CD38 quadruplet strategies in transplant-eligible newly diagnosed multiple myeloma. Thank you, Josh, for making it. Very pleased having you.
Thank you, Dr. Moti. And as you're a full professor, you will talk about ectoenzymes and Tregs and all of this. As an associate professor, to me, CD38s are like ice cream. Some people like chocolate, some like vanilla. In the end of the day, if you're getting ice cream, it's a good day. That's as simple as I will keep it. And thank you for those who are still here to listen to me. 66-year-old man, revised ISS stage 2 disease, fit, active lifestyle, performance status of 1, standard risk cytogenetics, has a little bit of high blood pressure and a little bit of dyslipidemia. So, I think we really have to dig right into this. So Professor Moti, I will start off just to throw it back at you. Is this a patient that you would deem quad eligible? Professor Facon, any disagreement? Is there any?
No, I never disagree with Mohammed.
So I guess the question to really throw back is, and I think we've been having decades of different trials trying to disprove autotransplant. As great as high-dose melphalan is, and I'm still a big lover of high-dose melphalan, we've been trying to get rid of it for years. And the question is, does quads change that? Are we achieving such deep remissions that maybe we don't need the the transplant anymore?
Well, I personally believe we still need transplant. I'm a transplanter, so.
We will go for transplant too.
Absolutely. Yeah, I still share this view that to bring it back to the realm of infections, myeloma is like infection. This is never going to be as sensitive as it is now. We haven't given 12 different cephalosporins. Let's kick the disease when it's down. So just to kind of go over a little bit again of what Professor Modi already mentioned, that in the EU, quads have been completely integrated into clinical practice, both in the setting of transplant-ineligible disease from Alcyone with DARA-VMP, and in the transplant-eligible groups with DARA-VTD from that Cassiopeia study. When we go over to the NCCN guidelines, which is the playbook I like to use, we have a number of additional options. And at least from a US standpoint, anything that is not specified the category in NCCN will be category 2A. And in general, 2A or better is typically reimbursed. So although we do have a DARA VRD as recommended, I think it's going to take a little follow-up from the Perseus trial, which has just been presented, to lead this to become Category 1 in NCCN. But we do have DARA VTD, DARA KRD, as well as DARA CyBorD from Lyra, and isatuximab RVD from the GMM-GHD7. So we have many flavors of ice cream, so we've gone beyond chocolate and vanilla to pistachio and cookies and cream. We have lots of options in the United States. So this is the Griffin study, and to me, this is one of the major transformative studies in myeloma. And the reality is that even with modern-day triplets like RVD, we're getting near 100% response rates. And I love that you come to meetings like this, and when you put up these graphs, we're not talking about overall response anymore. It's how deep can we get them? Because we have shown from upfront to early relapse and late relapse, the deeper remissions tend to correlate with durability. So it's really all about taking a disease as its most naive and a patient in many fashions who will never be younger and oftentimes never fitter, and take advantage of that to induce a deep as remission as possible and hopefully cure for some of these patients. And as we can see, as we go from end of induction all the way to final analysis, one of the big advantages of going from the triplet to the quad is that the marked increase in deep remissions, more CRs, more stringent CRs, and more MRD negative. But one of the questions that Perseus and Griffin still have not quite answered is, if you receive the CD38 upfront as part of your induction, do you still need it in the maintenance setting? And I think we're all very anxiously awaiting the results of the SWOG 1803 dramatic study in terms of who needs the double maintenance, who needs single, when can you stop? But I think we can glean a lot of information from the Cassiopeia study. So one of the brilliant designs of Cassiopeia is that after patients were randomized to either receive VTD induction or DARA VTD, after transplantation, they were then again randomized to receive observation alone as maintenance or receive daratumumab one dose every 2 months. And of course, we get the 4 groups: VTD nothing, VTD DARA, DARA VTD nothing, DARA VTD DARA. And although I still think we need to follow this longer, I think one thing comes very clear is that you need to have a CD38 as part of your induction therapy. The only line that is markedly different from the others is the patients who receive no anti-CD38. Now, I think we need longer follow-up to find out, is there a benefit of getting it both upfront and in maintenance? And again, that's the wonderful thing about myeloma. Even at 4 years, these patients, that line is flat. We have many years to follow this up. But I think the big important factor is CD38 needs to be part of your upfront therapy in one way or another. And now we have the phase 3 study Perseus, which again takes this to the full phase 3, randomized VRD versus DARA VRD. Patients undergo auto transplant, post-transplant consolidation, and then maintenance, either lenalidomide or daratumumab and lenalidomide, with an option of discontinuing the DARA only after 2 years of MRD negativity. And again, first thing to say is that the comparator arms here are still wonderful. This is not like a number of years ago where every CLL trial came up against chlorambucil, and you would say, okay, you beat chlorambucil, so what? That data is not translatable. VRD is still a wonderful approach, but we can clearly see more patients are maintaining their remission at 4 years when you go from the triplet to the quadruplet. So I think the data is clear that the efficacy is better, but there's no such thing as a free lunch. So what are we getting in return in terms of toxicity? Well, there's several things. Anytime you have any trial that's 2 versus 3 drugs or 3 versus 4, and the more drug trial wins, that regimen will always have more cataracts, edema, hypertension, upper respiratory tract infections, and one of those reasons is longer exposure to dexamethasone. So I think that always has to play in there a little bit. That being said, CD38 is expressed on a lot more than just plasma cells, so we do see more evidence of neutropenia with the quad. We do see more evidence of thrombocytopenia, although typically quite manageable. Now, the big question has always been, well, what's the optimal CD38, DARA or ESA, and what's the optimal proteasome inhibitor, bortezomib or carfilzomib? And I still think this is a little bit debatable, even though the Endurance trial did compare VRD versus KRD that was limited to patients not moving forward with transplant, and at the time they excluded patients with high-risk cytogenetics. But Francesca Gay presented as a plenary at this most recent ASH the first look into the ISKIA data, looking at ESA KRD versus KRD, mobilization, transplant, post-transplant consolidation, and then my new favorite term in myeloma, light consolidation. Light consolidation is a quadruplet. I would disagree on the term light, but it is lighter than previous. And what we can see is that, again, we are deepening responses. The baseline is near 100% response rate, but we look at next-gen sequencing MRD, 10 to the minus 5, 10 to the minus 6. Those are the patients that are having this flatter curve. Those are the patients that we're starting to approximate actuarial survival. I think Hira presented earlier a wonderful slide talking about what is the life expectancy of someone who is 80 and what are our goals. If you can approximate life expectancy in an older patient, that may be tantamount to cure for some, but for many, we're actually getting such deep remissions, kicking the can so far down the road, maybe not cure now, but maybe around for the cure in the future. So again, when we're going from the triplet to the quad, what are we adding in terms of toxicity? You're adding more cytopenias. We know that. We do have an increased amount of infections. Again, a lot of CD38 expression in the pulmonary vasculature, but otherwise, in general, going from a triplet to a quad with the addition of a monoclonal antibody is not a huge ask. This is not like the old days of classical chemotherapy, where if I said, I have an 80-year-old, bless you, if you had an 80-year-old with some solid tumor, and I could give you a good response rate with methotrexate, adriamycin, and 5-FU, but don't worry, you could add bendamustine and it'll be better, that's a big ask for an older patient, and many of our myeloma patients are. But how often in the lymphoma world do we just add Rituxan or just give Rituxan? So I think incorporation of new therapies and incorporation of antibodies really is optimizing these patients. Again, more data with the ESA-KRD combo. This from Betsy O'Donnell. Overall response rate, 100%. That's where we're starting off. Amazing. Progression-free survival rate so far, 91.3%. MRD negativity rates quite high. Again, I think we need a little better playbook moving forward of who needs ESA, who needs DARA, who needs bortezomib, who needs carfilzomib. I think we have a little inclination. Someone with baseline bad neuropathy from diabetes, we would often choose a carfilzomib-based approach. Someone has bad cardiac disease, we may choose bortezomib, but I don't think it's always clear-cut. And again, another trial which I think is absolutely wonderful, the GMM-GHD7. And part of the reason I really like this is that this more mimics at least our approach in the US, where post-transplant consolidation is not commonly administered. And as opposed to Perseus and Griffin that gave induction, transplant, post-transplant consolidation, and maintenance, HD7 gave induction, transplant, and went right to maintenance. And again, the MRD negativity rate and the depth of response pound for pound is much farther superior with a quadruplet over the triplet. Okay, so let's take this a little bit different because I think exactly as Joe McHale pointed out in an earlier session today, it's very granular. It's at a patient level how we make these decisions. So Professor Modi, I would turn this to you. High-risk patients, is there a quad of choice for high risk, or how would you approach it?
Absolutely positive. The debate for me is not about quadruplets, is maybe here the use of carfilzomib instead of bortezomib.
Absolutely.
Okay, I can play the controversy, and okay, there is no head-to-head comparison of carfilzomib versus bortezomib in this setting. But okay, I think the majority, there is some kind of consensus that accepting that carfilzomib might be a little bit better for patients with high risk. So, and the IFM did ACCRED for everybody in the MIDA study.
So let's dig a little bit into the forest plot for Perseus when it comes to some of the high-risk subsets. So both from a revised ISS standpoint, ISS standpoint and a cytogenetic standpoint. And we can see in both cases here, both in international stage 3 patients, which generally perform worse, and the higher risk cytogenetics, we do see the forest plot just to the left of one showing superiority. So I do think high risk is not about an all or none. It's about chipping away and using every little piece. Adding the proteasome inhibitor chips away at part of it. Adding the CD38 chips away at part of it. I don't think the lenalidomide adds all that much, but the more you chip away, the better you can do overall. And again, when we start looking at the other quads like Ischia, I think in general we start to see a similar pattern. Of course, one of the things that we will note is, first of all, this is not PFS. This is still MRD negativity data. And we still are starting to recognize that not all bad myeloma is the same. So it's no longer, I think, standard risk and high risk. The ultra high risk, 2 or more high risk cytogenetic abnormalities, those are really the patients that have a completely different pathway in terms of how they're going to do. But here, at least at the 10 to the -6 cutoff, in general, we are still seeing improvement in the ability to achieve those deep remissions, even in the ultra-high risk, the revised ISS 2 and 3, and the 2 or more high-risk cytogenetic abnormality patients. Another wonderful study was the GMMG concept, and I think this study is emblematic of things that we ought to do in myeloma that we don't do enough, is really aiming at the worst of the worst, including the plasma cell leukemics, including the EMD, including the patients that otherwise are going to do poorly and just hit them hard. So this is the ESA-KRD study, and we see here in the transplant eligible, MRD negativity rates of 67%, the transplant eligible getting up to 81% at any time point. And again, not all CRs are going to be the same. I think Xavier pointed that out earlier today, and maybe all MRD negatives are not the same, but I think we're starting to play at a different level and really getting these patients that are likely to do worse, getting them into that extremely deep remission is absolutely key early on, because the likelihood of getting them back there in subsequent therapy becomes less and less very quickly. So really just to sum it up, I think the data from these trials support that CD38 quads really are the standard now for transplant-eligible patients. And whether or not you proceed with a transplant or not, if you conceive that patient as being fit enough, healthy enough for a transplant, in my mind, you've already said they are eligible and healthy enough for a quadruplet. I think we can argue here, is it DARA or ISA? Is it bortezomib or carfilzomib? Pick your favorite flavor of ice cream and enjoy. But I think we're starting to add more drugs, killing more subclones, and the killing of more subclones leading to deeper remissions by adding more and more tolerable therapies, and CD38s tend to be quite tolerable. I think we're going to start to reach a point where perhaps with the quad induction, there are a subset of patients with better risk disease who get deep MRD status that maybe don't need the auto transplant after all. I am kind of like Professor Moti, I love transplant. I still haven't found a drug that you can infuse for less than half an hour, and a decade later, some of these patients are still in remission. So it's going to take a lot to get rid of melphalan. And then, of course, what is the ultimate strategy after? Do you still need the CD38? Can you back off? When and how? And again, I think the dramatic study will get us a very far way into understanding that. And with that, I will pass this to my extraordinarily esteemed colleague.
So we have a patient for, so the good thing for George, he had a lot of studies to talk about, and I don't have so many studies. I have study designs for you, but you may have to wait for a couple of weeks to have to get some study results. So the patient here is a 75-year-old lady with newly diagnosed myeloma, compression fracture, and COPD, and she has a standard risk cytogenetics. And the question is, assuming that transplant is not an option, is this patient a candidate for a quad, or would a triplet be appropriate in all cases? So should I ask the question to Josh and Mohammed, or?
Sure. So I think in general, I approach many of these with triplets, but I have a number of patients that present with very high burden disease. I saw a similar patient a few years ago now, that had an IgG of 11 grams. I did not feel comfortable just giving a triplet, so I give what I call Grifamaya, the Dara RVD up front, and to Dara Rev long term.
I'm a bit biased because I have really a positive experience with our IFM protocol on those guys who got quadruplet, benefit protocol. And I've seen them doing very well. So I have a sort of a tendency to try to go to quadruplet whenever possible.
Okay. So if a quad is being used, how is this platform delivered differently in transplant ineligible patients? Would dose reduction modification be useful? What is the EU and US experience with quad in transplant ineligible patients? So here we will move directly to basically the ESMO EHA guidelines you have seen many times. What we have today for transplant ineligible patients are basically mostly 3-drug regimens, so such as DRD or VRD. And if you go to these recommendations here for non-transplant candidates, you have again the VRD, the DRD, and some other regimens as well. For example, the combination, so the DVMP or the combination of daratumumab with cyclophosphamide, bortezomib and dexamethasone. Here we have to make things a little bit clear. You could, I would argue that DVMP or DVCD are not real quad regimen. Okay, that's a semantic point, but basically what we call a quad is the combination of a PI, an IMiD, and a CD38 with dexamethasone. So some other regimens have incorporated either melphalan or cyclophosphamide, basically DVMP, or the same with cyclophosphamide. So these are, you could say these are technically quad regimens, but by what we have in mind is basically the combination of a CD38, an IMiD, and a PI. So, but still few words about these regimens having an alkylating agent. So this is the LIRA study with DARA Cybordi, followed by DARA maintenance. And as you can see, these are small groups of patients anyway, but in transplant ineligible patients, you can achieve response in more than 80% of patients, in fact, including approximately 30% of patients having a complete response. So these are you could say these are not bad study results, but if you go back, for example, to the DRD regimen, you will achieve complete response in more than 50% of patients. So this is the Alcyon study has been presented several times, and you know it perfectly. The median PFS was a little more than 3 years. This is not, again, this is not from my point of view a real quad regimen, but this is an interesting regimen. I would like to add here that by design, DVMP had DVMP and then daratumumab maintenance, daratumumab given as a single agent, so that this regimen might be improved with having more bortezomib. So if you, and I know that Dr. Mateos and Spanish colleagues have did investigate a longer exposure to bortezomib. So the maintenance might be some kind of bortezomib in combination with daratumumab, and in doing that, it's likely that the PFS will be at least a little bit longer. We have here we have looking at study results. We have now we have this Spanish study again, and the first thing I would like to share with you is that the study was called GEMFIT. So this is we already mentioned yesterday on that we have studies for frail, but we have studies for fit. So this is possibly the first time we had a study for elderly fit patients. And these patients had an age between 65 years and 80 years, and the study was presented at ASH at the end of last year. And so the study had 3 arms. So this is an academic Spanish study. The control arm was VMP followed by lenalidomide dexamethasone. It has been investigated some years ago in Spain again. And the 2 investigational arms were either KRD or the combination of daratumumab with KRD. And interestingly, this is a study for fit patients, but still, some patients are more frail. That's life. So you can anticipate that some patients between the age of 70 and 80 years are less fit or more frail, and thus this was assessed by a geriatric score. So there was a frailty assessment by this score called GAH, and basically the lower score is associated with the better status. And so on the left-hand side you have let's say the best patients. On the right-hand side, you have the more frail, and it's not so easy to interpret because, for example, what you can see, if you look at dara-KRD, it's indeed better for the more fit patients, and it seems to be less effective in a way, at least for PFS in the more frail patients, but it's also the opposite for the KRD arm. So it's not so easy to interpret, but one important thing are the bottom lines. And for example, if you look at this, you will see that the most frequent reason for toxicity-related deaths in the 3 arms is infection. And they observed 13 death events among 153 patients in the dara-KRD arm. So this is something important to keep in mind when you treat elderly patients, even though these patients are considered to be fit, and even so you did not treat patients over the age of 80 years, which is the case here, having quad regimens might be associated with more toxicity and some additional death events. We have, looking at the traditional quad regimens, we have this phase 1b study, which was the combination of isatuximab with VRD. So this study was basically a kind of rationale for the phase 3 IMRO study. And in this particular study published by Dr. Osho in Leukemia in 2023, you have a group of 73 patients receiving 4 6-week cycles of ESA-VRD followed by ESA-RD in 4-week cycles, which is basically the treatment schedule for the EMO study. And as you can see, the vast majority of patients achieve a response, and a very high fraction of patients achieve at least a very good partial response. So 90% of patients achieve at least a very good partial response, and 51% of patients achieve MRD negativity at 10-5. So that being said, this is the EMROSE trial. You will see at ASCO on EHA. Based on the previous experience with the phase 1b study, so this is a comparison between VRD and isatuximab in combination with VRD for transplant-ineligible patients. Importantly, we excluded patients with an age over 80 years, and so there was a 2-to-3 randomization, 3 patients for ESA-VRD versus 2 patients for VRD. So we had 4 6-week cycles followed by 4-week cycles with either RD or RD alone, and the patients who progressed in the continuous part of the VRD arm, so patients who progressed on lenalidomide and dexamethasone maintenance had the opportunity to cross over to ESA-RD. So the primary endpoint was PFS. I have only just 2 additional slides for this. So this is the regimen, and so it looks a little bit complicated, but the one point here is to say that it will, as I said previously, when you have to make a comparison between different quad regimens, maybe not only for the elderly, but you have to know exactly how many cycles you delivered, how many doses of bortezomib or CD38 you had to deliver, and you will see that you will probably see some differences between studies. So Mohammed did this slide based on the ASCO abstract, so this is public information, and as shown here, in fact, there was a great benefit in favor of the ESA-VRD arm in terms of PFS. So the study met its primary endpoint of PFS. The median PFS for the VRD arm was 54 months, which is quite long. So this is an extremely good VRD arm. And the hazard ratio is 0.59. So this is a 40% reduction in the risk of progression or death. This is also an ASCO abstract. This is an EHA abstract too. The study is an academic IFM study called BENEFIT. So BENEFIT is IFM 2020-05. And just to explain a little bit the rationale for that, if you remember, the DRD regimen was presented for the first time at ASH 2018 and published in the New England Journal in 2019. So in the EMRO study, patients were enrolled from December 2017 to March 2019. So at the time the EMRO study started, we had no, the DRD regimen was not, did not exist, I would say. So the control arm was VRD. Then in around 2019, the IFM decided to move forward with another ESA-VRD study, having an ESA-RD control arm, so a kind of equivalent of DRD. So the 2 studies are, in a certain extent, sister studies. So one, the registration study, EMROSE, as a VRD control arm, because VRD is an approved regimen for transplant-ineligible patients, and the academic study, this one, as an ESA-RD control arm with an ESA-VRD investigational arm. So the study has an MRD primary endpoint, and so at the time of ASCO, you will see MRD results. And as shown here on the left-hand side, the MRD negativity at 10-5 at 18 months was significantly higher in ESA-VRD as compared to ESA-RD. 47% versus 24%. We have another ongoing study which will read out likely soon. This is the CEPHEUS study, having VRD versus subcutaneous daratumumab in combination with VRD. So this is another extremely important study. Importantly, the IMRO study did exclude patients with an age over 80 years. The CEPHEUS study has excluded the frail patients based on the International Myeloma Working Group frailty score. So this is, in my opinion, this is something very important to keep in mind, assuming that all of these studies, CEPHEUS, BENEFIT, IMROS, are positive. In fact, it will mean that this regimen would be suitable for non-frail or patients below the age of 80 years, which means that we are clearly dealing with, let's say, elderly fit or elderly non-frail, whatever you want to call them. So this is something important to have in mind. So what if Selina had presented with high-risk features? So that's basically the same question we had previously. Would you be more or less likely to utilize a quad if a patient has high risk? Is there an ideal partner for CD38 in high-risk patients who are transplant ineligible? And I will not ask the question here. We have very few study results here. I would just like to share with you this slide from the concept study. So the concept study had a big part with transplant eligible patient and a smaller part with transplant ineligible. So as you can see, the study had 26 patients who were transplant ineligible, and these patients had, by study design, high-risk myeloma. And interestingly, MRD negativity was quite high. So about 70% of patients achieve MRD negativity at any time point. And if you look at sustained MRD negativity for more than 1 year, they found approximately 46% of patients. So this is a small group of patients, but it shows that at least in terms of MRD negativity, these high-risk patients can do well with this ACCME regimen. So just, I still have just a couple of slides. So this one is just to recall the principles for delivery of CD38 antibody therapy, and I will not spend, so we are a little bit late. I will not spend a lot of time on this. This is regarding prophylaxis, infectious prophylaxis, and premedication, etc. And finally, and looking at the we already have subcutaneous daratumumab for some years, and isatuximab may become a sub-Q with a special device in some time as well. And so there is an ongoing study looking at this special device for isatuximab delivery.
So I think the data presented by both Josh and Thierry are really fascinating. Obviously, as I mentioned, Josh's task was slightly easier because obviously in the young and transplant-eligible patient, having quadruplet is now well-established. Dara VTD has been around for some time. When we had kidney insufficiency, Dara VCD has been used, and now Dara VRD, although it's not approved, can be an option. It's slightly more difficult indeed in the non-transplant eligible but definitely I think the age issue, but you clearly highlighted, Thierry, the issue of fitness and unfitness and in between. And it looks like, based on what you have shown us, that if you are in this group of patient who is so-called old but fit, clearly we are able to deliver these quadruplets. Any thoughts? Josh, what are you doing in your practice today?
For quadruplets?
For these so-called elderly but fit patient.
So, I still believe that transplant is always a question of risk and benefit. And that is not a fixed point in time. So we may see someone a little bit older, and we may say, I think the risk may be too high. But someone who has early relapse from quadruplet therapy, I think that dynamic changes. So many of these patients, I still collect stem cells to have that option later on, even if that's not the initial intent.
Thierry, are you in agreement with this approach?
I agree with this approach. I was confused about the first question we had online.
So the question online is, any thoughts on which type of patient you might start with a standard triplet, let's say VRD, and then add a CD38 as maintenance? And indeed, that was reflected in one of the first polling questions, where the group was still unsure about whether you need an anti-CD38 monoclonal antibody during the whole journey or at some point.
I would say, okay, so that's not a so easy question. I would say from my point of view that a standard triplet has a CD38. So the standard triplet is basically VRD. But having said that, I recognize, so I heard about the Banya's presentation, and so you cannot just say that DRD is a regimen for every country, unfortunately. And so just as a follow-up comment, I think there was a discussion on cheap lenalidomide, and you could say lenalidomide is cheap in a certain extent, and I would ask for some cheap or low-cost CD38, because I think if you could manage an affordable regimen combining some lenalidomide and some CD38, whatever the CD38, you make a lot of difference in terms of clinical outcome.
Excellent. Professor Lalit Kumar.
Slightly different track. Like for the age-wise, like one of the question was, and especially in last 2 days, what we have been listening that the age for trans like 65 is like kind of cut off. But in the last 10, 15 years, I think a lot of papers from US and other parts also that you can go up to 70, even 75, you can do outpatient transplant, this and that. So now, are we going back to the 65 or we are still doing above 65? That was the one question. So maybe...
I think if you ask Mohammed and myself about, so we proceed with transplant up to the age of 70, let's say. But what is probably true in our country is that as we will move forward with quad regimens, at least some patients close to the 70 or patients between 70 and 75, you may say that these patients might be eligible for a quad regimen without transplant. So from my point of view, you will see in Western Europe, let's say, and in the US, you may see less patients proceeding to stem cell transplantation, especially between the age of 70 and 75. That being said, I will go back to the same discussion. Transplant is a very cost-effective procedure.
In fact,
and I would not you should not forget transplant, because it makes a lot of difference in terms of clinical outcome. And in many countries, you can manage transplant, not for all patients, but at least for a good proportion of patients. But you may not have access to CD38 or more sophisticated drugs. So if you can manage some VRD and some melphalan 200, you still do a very good job for patients.
In fact, this is what I was supporting the Dr. Hungria's presentation, that it's easier to do transplant till the time we get the CD38, anti-CD38 molecules, which may take a couple of years.
I think we are in agreement that maybe the minimum effective regimen today worldwide depending on affordability, would be a triplet with VRD, VTD, and melphalan and len maintenance. But we are data-driven, Thierry, and although you said that we may prefer transplant, in Perseus, when we look to the subgroup analysis, and this is very clear, there is a gray zone for those patients between age 65 to 70. And I think that echoes Professor Kumar's question that maybe in the near future, especially when we will see the IMROSE results, we will be more and more reluctant to push the boundaries, I would say, or the limit of age. Josh?
I think we've been talking a lot about, do we still need transplant? I think it's clear that not everyone improves, but there's never been a study, to my knowledge, that you do worse with transplant. And there's some people who do dramatically better. And although overall survival is still the standard, the increase in progression-free survival that we're seeing with autograft, especially with the rate that new technologies and new drugs are developing, I still think has a lot of value.
Excellent. So we have a question I can handle very quickly, whether we should keep our anti-CD38 monoclonal antibody until the end. I think the philosophy of treatment is to use your best tools, your best drugs, your best bullets as soon as possible. This concept of, I'm going to keep the best, it's like, you're having a Ferrari and you keep it in the garage because you don't want to.
It's just a little unrelated.
Very quick.
Yeah. This is about the lenalidomide dose maintenance. Like normally we have been saying that we should be giving for 3 years. In practice, at least, we have found that after 2 years becomes a little difficult to give for 21 days. Generally, we kind of get a lot of cytopenias. First 2 years generally much more easier. But then beyond that becomes a little difficult. So sometimes we have to compromise to give 2 weeks on, 2 weeks off. So like, what is the general experience?
The experience we have with lenalidomide maintenance for us is very simple. So we give 10 milligrams. I think we don't try to escalate to 15 or so. That was done in some studies. So we take 10 and then there is a discussion on whether patient may receive 2 or 3 years of some kind of continuous lenalidomide. What I can tell you is that in my own practice, I give lenalidomide maintenance for at least 2 years. And then I think at 2 years or at 2 to 3 years, you may have a discussion with patients, in fact. And they may, if they say that the response will likely be good or very good or extremely good, and if they complain about toxicity, some of them will discontinue. Some of them will remain on continuous lenalidomide, but okay. And that may change with the availability of CD38 in combination with len for maintenance.
Wonderful. Thank you, Thierry.
Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/QTT860. This activity is supported by an educational grant from Sanofi. This activity is certified by PVI, PeerView Institute for Medical Education. Remember to download the slides and practice aid.